Well, thank you, Dr. Mufti and Dr. Khan. We really do appreciate the invitation to come back. And just a small correction, Dr. Mufti, I did not check in last night. I checked in this morning. What we'll speak about for the next few minutes is cardiovascular risk stratification. And here are my disclosures. The objectives will be to learn the different risk stratification formulas available to estimate coronary artery disease risk, understand when to use the different risk formulas based on the characteristic of the patient, and then appreciate the ability of these risk formulas to actually predict future cardiovascular events. I think we're starting with some questions here. Which of the following are not used for cardiovascular risk stratification? Diabetes, hypertension, HDL cholesterol, LDL cholesterol, or total cholesterol? Okay. The majority say total cholesterol. The next was HDL cholesterol, then LDL. Do you want me to tell the answers now? Or?
No, after the talk.
After the talk, okay. Very good. Oh. So the next one, coronary artery disease, or CAD, risk stratification formulas are available for which of the following types of patients? Those who've never had a diagnosis of coronary artery disease, those with known coronary artery disease with a prior coronary angiogram, those with known coronary artery calcification by CT scan, those with no known cholesterol levels, or all of the above. And all of the above is the majority answer. The third question is, in what year was it shown that there are more people worldwide that are obese, BMI greater than 30, than significantly underweight, BMI less than 18.5? Now this is in the world. This is in for the last, 3,000 years that we've had some kind of a record of things. Was it in 2000? Was it in 2006? Was it in 2016? Is it estimated that it will occur in 2026? Or this is absurd, it's never been shown. All right. So 2006, it was estimated as the plurality answer. I can give you one factoid now, and that is around 2006, it was found that more people died in the world of overeating than undereating. It was, we went from infectious disease as the #1 cause of death in the world to non-communicable diseases, which was mainly self-imposed, overweight, lack of exercise, things like that. So let's talk about risk stratification. So say you're in your office, a 62-year-old man comes to see you for his cholesterol. He works as a construction foreman. He's fairly active, though no regular exercise. He's a pack-a-day smoker. His father died at age 58 from acute MI. He's not been to a doctor in over a decade, which usually means that either his wife is making him come, or he's starting to have something go on. He doesn't feel quite right. He's on no chronic meds, but he just started aspirin. I wonder why. He just started aspirin, so maybe something is fishy. He feels some symptoms. His height is 178 centimeters, weight 101 kilos. That gives a BMI of about 32 or 33. Heart rate 88, blood pressure high, 148/86. His exam is clear lungs, but he does have a fourth heart sound on his cardiac exam. His fasting blood sugar is 98. He has a CBC, the thyroid studies, electrolytes, creatinine are all normal. And his lipids are shown here. Cholesterol 144, triglycerides 85, HDL may be a little low at 44, and LDL is 83. So regarding his cholesterol, what is the next best step at this point? Start him on a statin, calculate his risk for a CV event, suggest he see a dietitian, perform an exercise test, or suggest he quit smoking. So I don't think we don't need to do the audience response on this, but what would you do for this patient? And the recommendation is to calculate his risk of a cardiovascular event. Because patients walk into our office, we don't know, we think we can risk stratify them, and we know we all do risk stratify people. We do it all the time. You do it every day in your office. You see things, you hear things, you smell things. Well, what do? You see a guy with a big BMI. Well, here's a guy who plays for the Texas Rangers, and he has more You know, I have more fat in my little finger than he has in his whole body, you know, so what is it just because his BMI is high? Or you smell your patient and they smell like smoke. You do that all the time. You recognize that. You hear him tell you that he's a couch potato, and you use your tactile sensation and then go out and measure his waist. So we do these things all the time. But if you look at the risk of patients, if you look at hypertensive patients, you just had a great talk on hypertension, and you look at the 5 healthy lifestyles in people that are hypertensive, and this is from the BRFSS, which is the CDC, where they call hundreds of thousands of patients every couple of years. And they said there are 5 factors in hypertensives that they've looked at. Are they limiting alcohol? Are they not smoking? Physically active? Eating 5 fruits or vegetables a day? And are they normal weight? And you can see that 94% of them do limit alcohol intake. 81% don't smoke, so 19% of us are smoking. Less than half of us are physically active. Fruits and vegetables, only 1/3 of us, and normal weight, only 1 in 5 of us. So you have a patient walks in your office, you can ask them where they're from. What's your zip code? This is actually the risk of doing these things. How many of these do you do? And you can see if you're from Tennessee, you have a less than 1% chance of doing all these things. If you're from California, you're the best in the country, but you're still only 6%. The average is about 3%. So all of us, basically, what I'm trying to say, are high risk. We are a country of high risk people. Now, there's other things you can do. Maybe you wouldn't do this in the waiting room, but you could. There's a 50% increase in erectile dysfunction if your gut is so big you can't see your junk. And I'll tell you, 1 in 3 men in the United States cannot see it. If you are in your 5th decade of life and you have erectile dysfunction, your risk of having coronary disease is 50 times higher than a guy who's age and sex matched for you, risk factors. 50 times higher if you're in your 5th decade of life. So there's different ways we risk stratify people. But the problem is, if you look at the prevalence of risk factors in people with coronary disease, this is a large study, old study, 13 years old. You can see in 90,000 patients with known coronary disease, 2/3 of them either have no risk factors that we classically call risk factors, the smoking, hypertension, cholesterol, diabetes, or just have 1 risk factor. So we really need a better way to assess this. So what I end up doing, what is very commonly done, is use clincalc.com. Just type that in. I think the web is much better than the app, because you can go on the web within 6 seconds. I do it all the time in my office. And I tell patients to go on it. I give them the clincalc.com address and say, you go do this and figure out your risk and figure out if you change things, how it improves. So go to the pooled cohort 10-year risk assessment, and this is the same pooled cohort that the American College of Cardiology, American Heart Association has suggested we use in the guidelines for risk stratification. It's just a much easier one to use than the one from the ACCHA webpage, which is very, very user unfriendly. So you bring up this page, you can put in what you want to put in. You can put in that this is a man, a male here. He is 62, white, 144 cholesterol. You get the idea, smoking or not. Then hit calculate, and what will come up is his risk for 10 years. His 10-year risk of atherosclerotic cardiovascular disease event is 16%. And the event is a heart attack, a stroke, or a fatal event of one of those two. And it shows it here graphically, 16%. And if it was ideal, optimal risk factors, you could see his risk would be 6.9%. So you hover over this little question mark here and say, what is ideal? Click right there, and it will tell you that the optimal risk factors is a total cholesterol of 170 for this gender and age, HDL cholesterol of over 50, systolic blood pressure 110, which may be a little bit low, although for this young of a man should be fine, not taking medications for hypertension, not diabetic, not a smoker. So the patient can go do this and say, well, what if I raise my HDL or stop smoking? What does my risk do? And they can see these results just as easily as you can. And if patients say, I can't figure this out, say, good, you have maybe an 8-year-old child that lives next door to you. Go ask them and they'll show you how to use this. So once you get this, the risk stratification, the guidelines have pointed out who benefits from statin therapy. The 4 groups, if they have clinical atherosclerotic cardiovascular disease, if you have coronary disease, you benefit. If you have an LDL over 190, those would benefit. But if you're not one of those 2 groups, it's recommended for diabetics in the 40 to 75 age range that have an LDL from 70 to 189. And for those of you from Canada, the millimoles are here. And if you have a 10-year risk over 7.5% with an LDL of 70 to 189, that would be a group that should be considered for cholesterol lowering. That would be our gentleman here. So the 4 groups graphically, you can see on the left is the ones with known disease, on the right is the familial hypercholesterolemias over 190. The diabetics here on the left-hand side do a 10-year risk evaluation. If their risk is less than 7.5%, probably still give them something like a moderate to high dose statin. And if it's over 7.5%, give a high dose. And then our gentleman would fit in this no diabetic group. He's certainly this age range, this LDL. Do a 10-year risk like we do on him. If it's over 7.5%, then think of a moderate to high dose statin. So he would fit that category. Now, if you look at the distribution, say you did this to every adult in the United States, and they've actually modeled this computer-wise, and look at the distribution of 10-year risk in patients that don't have disease. Remember, this is only for patients that don't have coronary disease. The non-pregnant population, the women and men, you can see here, and on the x-axis on the bottom is very low risk, less than 2.5%, and then here's 7.5% and higher on the bottom right. And you can see women, it's interesting, about half of all women throughout their lifetime are very low risk, less than 2.5% risk. No matter what, even the ones that are 79 can fit in that category. Men, however, you can see about half of men at any point in their life, from age 40 on up to 79, are in the high risk, what we call high risk, over 7.5%. Now, in Europe, they call high risk, what? 5%. It's confusing because this is all based on Framingham, but Framingham, remember we used to call Framingham high risk 20%, which I thought was pretty high, especially if it was me. If it was my risk, I'd want it to be about 1% for 10 years. But the old Framingham was over 20% was high risk, less than 10% was low risk at 10 years. And so now we've changed that, and I'll show you why that's been changed. But the point is that half of all men are high risk now throughout any point in their life in this age range. Now, what are the available cardiovascular risk tools we have? I'm going to go through a few of them, but I just want to just give you the kind of the landscape, the 30,000-foot view. The Framingham risk score is, for instance, the one we use now, this pooled cohort. It looks at age, gender, diabetes, tobacco, systolic blood pressure, and then total cholesterol HDL. And this is all the other ones that are used. SCORE, which is the European, Q-risk, which is the United Kingdom, things like the Reynolds score, which they incorporated CRP, looking at inflammation. And it's interesting that if you look at the area under the curve, the higher the number, the more accurate it is. And we use the Framingham, so it's as good as any. Maybe the Procram is a little bit higher. But here are the risk predictors. And what I put here is what Framingham uses. And SCORE doesn't use HDL. So the main European one does not use HDL. The Q-risk, the one that's used in the United Kingdom, also uses what's above here, plus it adds in height and weight. Do they have atrial fib? Do they have rheumatoid arthritis? Chronic kidney disease, their ethnicity, family history, blood pressure. And if you look up and down this whole list, what's one thing you never see that we treat on every patient? LDL. LDL is never used for risk stratification, never. Not anyone, ever. But that's all we talk about. It's all we talk about with our patients. It's all we talk about at cocktail parties. We see friends and say, oh, what's your LDL? You know, that's all we talk about. But it's because we use the total cholesterol to HDL ratio and the HDL ratio level. It's also interesting if you look at where the data comes from in the sample size. You know, the whole United States we're basing on 8,500 patients that we're sampling. Look at the Q-risk in UK, over 2 million patients. The SCORE in Europe, 200,000 patients. So we've got a long way to go, obviously. But these are the risks, and they do have some for rheumatoid. They do have some for kidney disease. But the one for rheumatoid is like reading the quadratic equation when you were in high school math or something. It is so confusing. So the question I want to ask you now is how many of the first events of the United States this year are going to occur in high-risk patients. So if we looked at every first event, every heart attack patient that came in this year, how many of them would have been, if we did a risk stratification the day before, we would say, oh, they're high risk. You think it's 100% or maybe just 90%? Anybody think 90%? 75%? Two-thirds? It's got to be at least two-thirds, right? Half? Half? We got a few votes. Less than half of the events this year are going to be in high-risk patients. So we give this risk score, and patients go, I'm not high risk, thank goodness. I can go back and eat those cheese curds if I'm in Minnesota or Wisconsin. I can eat the corn dogs. I can eat all the salt I want. I don't have to stop smoking. It's very disturbing because we basically are all at high risk. So how do you incorporate other risk factors? We know that hypertension, the blood pressure, cholesterol, smoking isn't enough. Now, if you see someone that's high risk, you know they're high risk. But what if they're not? You know, how do you incorporate other risk factors? And the guidelines kind of point this out. This is a surgeon I saw recently who came to me and said he wants to know his CV risk. He's been reading about it and starting to feel his mortality, I think. He knows that he has no coronary disease, no symptoms. In 1990, his LDL was 135. In July of last year, his LDL was 140. He was started on atorvastatin, low dose. And then in December, his total cholesterol was 135, and his LDL had dropped from 140 to 80. So his pooled cohort was 4.5%. But he says, you know, I'm worried because my mom and dad both had heart attacks in their early 60s. And I'm concerned I'm getting, you know, my late 50s. So how do you incorporate family history? It's always been very difficult to do. You know, so what would you do? Would you increase his atorvastatin and say, listen, with that family history, we got to get your LDL lower? Would you check a lipoprotein(a)? Would you do a CT scan for coronary calcification to try to further risk stratify? Order genetic testing to see if he has genes that are, there's a very popular book now called Beat the Heart Attack Gene that a lot of my patients are coming to me and saying they're reading. Or say, there's no further evaluation, let's just keep doing what you're doing. Well, the guidelines try to answer this too. Who else to consider and what other factors do you look at? The guidelines have pointed out 4 or 5 things. First is if the LDL is over 160. That's an additional factor that you say, wow, that really is significant, especially if the patient's only in their 40s and have an LDL over 160. If the family history is less than 55 for a male first degree or 65 for a female. If the CRP is over 2. If the coronary artery calcium score is over 300 or 75th percentile for age or gender. And if they have an ankle brachial index of less than 0.9. The other thing you can do on young patients, if they're under 60, is when you get that risk, that number at 10 years, if the patient's under age 60 from that clinicalc.com, it will also give you a 30-year risk. And this is very helpful for young women. So a woman comes to you, she's in her 50s, her risk is very low. It's always going to be low, as I said, but look at the 30-year risk. And there it can be 50%. And you can say, wow, you know, 10-year isn't much, but your lifetime risk is much more, so you need to change now. And so the guidelines have actually said the additional risk factors, which ones are recommended, and they put it here. That it's recommended to take a family history on everybody, and we should be doing that anyway. It's recommended that HSCRP not be done on everybody, but it's something that does have data behind it. The coronary calcium score, as we'll talk about more in a minute, has been seen to be helpful, and the ankle brachial index. Ankle brachial indexes, do any of you do them in your office routinely? Y'all do them? That's great. If they're positive, it really tells you something, but almost everybody, you know, the positive rate's probably 10% or something. It's very low. The recommendation's not for or against apolipoprotein B. That's a more specific way of measuring the bad receptor on the LDL molecule. Chronic kidney disease, albuminuria, which is the same, looking at kidney function. And then do a stress test, look at their fitness. There's really no recommendation for or against that. And what's not recommended is carotid intermedial thickness, just for that alone. What is helpful is that when you do a carotid intermedial thickness with ultrasound, and also look for plaque, because the plaque is what is predictive if you have carotid plaque, but just the CIMT alone is not that helpful. The other thing that they didn't mention in the guidelines was lipoprotein(a), which they didn't mention because they said there's really no data. And then the other thing was the genetic testing. People are coming in saying, oh, doctor, I want my gene tested for my heart attack gene. I say there is nothing that's commercially available for that. what you can do, the only thing that I can suggest to patients is if you know their blood type, say there is a genetic link to a certain blood type that increases your risk. And what's the blood type? Type A has a 20% increase for heart attack. Type B has a 20% increase for heart attack. Type AB has a 40% increase for heart attack. It's probably because there's a loci on the gene very close to the gene that determines your blood type. That's all compared to type O, which is lower. So if you look at all these different other factors that I just talked about, the CT scan, things like that, that's actually been assessed and said these other risk factors, they call them novel risk markers in this study. What's the discrimination and the risk reclassification? Meaning, how well does it discriminate and tell you this patient's really at risk, and how much does it reclassify their risk? And the thing that really showed the best was the coronary artery calcium score. It had a net reclassification index, which is this NRI of 19, which is huge. If you get an NRI of a third of that, it's big, or a tenth of that is big, but 19 is just huge. So the CT scan for coronary calcium looks very helpful. And they compared it to other things, like do they have peripheral arterial disease? Do they have chronic kidney disease? That didn't help. Looked at carotid intermedial thickness. That did not help. Looked at CRP, fibrinogen, things like that. That did not help. So really the coronary artery calcification and the NT-proBNP both have additive benefits in many studies, but the coronary calcification by far and away is the most helpful. And here is the graph that shows it. This is just an operator-receiver curve, and you can see the coronary calcifications, the red line up here, and the more it is to the left, the more it helps you risk stratify the patient. So you can say, well, what does coronary calcification mean? What if it's negative? So here is a predictive, what's the predictive value of a 0 coronary calcium? So I do preventive cardiology all the time. I order these tests all the time. So I got one a couple of years ago, and it was negative. Whew. I was very happy because about 60%, or once you get to reach age 60 as a man in this country, about 90% of men have positive coronary calcium. And you can see in numerous studies of 100,000 patients, if you have a coronary score of 0, your event rate is very, very low. So if you have a coronary score of 0, you have a less than 1 in 1,000 chance of having a coronary event at 5 years. That's very helpful to know. The issue is, though, look at your survival according to your coronary scores. If it's 0, it's very good, but even having a 1 starts to put you at risk. And you can see even if it's 0, it's not 100% survival. And the reason is that even if it's 0 in certain patients, like smokers, like diabetics, they're more risk. And so don't let them get off and think that they aren't at risk just because they have a 0 calcium score. So we'll give them a warranty. It's like buying a muffler. How long does the muffler guy say your muffler is going to be good for? Well, it depends on if you drive over rough and tumbly roads or if you just drive to church on Sunday. So if you have a rough and tumbly road muffler guy, like a diabetic, like a smoker, it's only going to be good for a year or two. But if it's someone that really has a pristine lifestyle, the CT scan is good for probably 4 or 5 years. The other thing is that any calcium increases your risk. Now, if a 0 calcium score, what does it tell us? Well, it depends on the patient you have in front of you. So if you do a 0 calcium score, and you do an angiogram on patients, all comers, 93% of them will not have any significant disease, but still 7% will. If you do perfusion testing on all comers, these are different, these are the same study, 94% have no ischemia. But look if you have an intermediate risk patient. So this is that, maybe 4, 5, 6% risk over 10 years. If you have an intermediate risk patient, they have a 16% chance of having ischemia on a PET scan. So 1 out of 6 patients if they have intermediate risk. And high risk, asymptomatic patients, if you look at them in the emergency department that come in with an acute coronary syndrome, 70% are going to have obstructive coronary disease. So again, it depends on the patient that you see. So a negative calcium scan is helpful in low risk and intermediate risk patients, but in high risk, don't count on it. So clinical acumen is really key. What's your feel for the patient? And remember Bayes' theorem, which is that if you look for disease in a high prevalent population for that disease, you're going to find it a lot. if you look for it in low prevalent, and the classic example is breast cancer, mammogram in a 22-year-old woman who has no family history. If you see a spot on there, it's very unlikely on her mammogram that it's going to be something abnormal. But in a 60-year-old woman whose sisters all have breast cancer, if you see a spot there, it's very likely it's going to be something real. The other thing I like about coronary calcium scans is, does it affect the patient's adherence to statin therapy? Now, adherence to therapy, I don't know if you're talking about that much here this visit, but there's when you give a patient a statin drug, how many of them actually go down and get the prescription filled? About 4 out of 5. If they get the first one filled, how many get the second one filled 3 months later? About half. So at 3 months, you have less than half the patients taking the statin. And is that unique to statins? No. Dr. Kahn, what % of patients nationally are taking clopidogrel, Plavix, after a drug-eluting stent? I mean, it's about half. I mean, if I got a drug-eluting stent, if I had a choice of taking my Plavix or eating that day, I'd say I'd take my Plavix. You need to take it. But you can see that if you have more calcium on your scan, you're much more likely to be adherent to taking your statin, and either based on the score or the quartile, comparing you to other people your age and gender. So it is helpful to get people to adhere to taking their therapy. And so it's so important that actually the MESA study has generated a lot of this data. MESA was a NIH-funded study, the multi-ethnic study of atherosclerosis, and they've come up with a risk profile. And so MESA has in it what the pool cohort has, the Framingham has, but I've underlined the other things. It's new. It has coronary calcification, so you can put that score in. It has ethnic groups like Chinese and Hispanic, which we don't have in the pool cohort. It has a family history of heart attack, and it has lipid-lowering medications if you're on them or not. So in our patient we talked about, 61-year-old man, we put in the calcium score, say we scanned him, this is the patient I talked about earlier, say we scanned him and he had a 0 calcium score. Instead of a 6.9% risk, he has a 2.6% risk. So it actually lowers their risk. And if you look at how much calcium scores can change your risk profile, it's shown here. In people that have been recommended statins, if they have 0 calcium, which is the blue on the bottom, about 40% of them in large cohorts really won't need a statin. But look at the ones where statin's not recommended. While 80% or 79% are not recommended, they don't have calcium, another 20% do have significant calcium. So it really can help you adjust your recommendations to a patient. And the other thing that's of interest, the calcium score will tell you that for a 61-year-old man, here it says the estimated probability of a non-zero calcium score for a white man is 70% at age 61. That's a little bit lower than what I told you earlier. It depends on the database you look at, but clearly most people get it as you go through life. So to summarize the risk, the other risk factors, what if your patient has a risk of less than 7.5%, but you're concerned? So say it's a 52-year-old woman with a risk of 6.8%. So it's under 7.5%. You say, well, her LDL though is 170, or her 62-year-old sister just had a heart attack, or her CRP is elevated, or her calcium score is high for age and gender, or her ankle brachial index is low at 0.8. If any one of these things, or she has a lifetime risk that's kind of high, 28%, any one of them, then the recommendations, the guidelines, are to understand this increases her risk. And like anything, it's shared decision making. You have to talk to patients about their risk. You discuss it with them, you suggest to them, and in this case, you can suggest either lifestyle, which we should always do with every patient, talk about alternative therapies that they can take to lower cholesterol. I'll show you my email at the end if you want me to send you our alternative therapies brochure. We give patients like this, or suggest medications to actually lower their cholesterol. Now, through very extensive research at Mayo Clinic, we found that overweight women actually have a decreased lifespan. That's been shown, I think, pretty clearly. But the key research at Mayo was we found that the woman still lives longer than the man who actually mentions it to them. So what do you use what risk calculator do you use when coronary disease is present? Do we even have? I mean, it's not risk anymore. I put risk in quotation marks because it's not risk. They have disease. but what's their risk for a future event? And that's where the courage calculator comes in. I don't know if you all use courage much. The courage study was the study that came out about 8 or 10 years ago that compared aggressive medical therapy, optimal medical therapy, and risk factor reduction alone to patients with known disease, compared it to a PCI plus aggressive medical therapy reduction, and found there really wasn't much difference. So you need to control the risk factors. So in the courage, they put together a risk profile, and here you can see it includes the number of diseased arteries, if they've had prior revascularization, smoking, heart failure, and their HDL. And you can see here their 5-year risk, or it's a 5-year risk, not a 10-year risk. So it's very interesting. If you look at a 61-year-old female who has 3-vessel disease and is a smoker, had a prior PCI, her risk is 42% over 5 years for a recurrent event, for an MI or death. I mean, that's huge. And if you say, well, why don't you think about stopping smoking? That'll lower your risk down to 36%. Will that be enough to get her to stop smoking? I don't know. But at least it lets her understand that she has things she can do to improve her future. Now, one thing is that Bill Bowden, who was the key investigator on courage, the principal investigator, he has put on the web page for the courage risk calculator, says that this is a caution. It's a beta version. It's never been verified by a second independent study. But I'll tell you, all these risk profiles I've talked to you about, all these risk calculators, they've been looked at. They've said, yeah, they can predict risk, but no one has ever used it to actually intervene, to change their risk and show that it actually lowers event rates. We just assume that's the case, but no one's ever shown that in a prospective randomized trial. Now, the other risk factors, I think this is very interesting. I don't know if you saw the Wall Street Journal and the NBC News about a month or two ago. It was around April, and you know, at Mayo, you work there, and they call you one day and say, okay, NBC News is going to come, and the Wall Street Journal wants to interview you about this thing. And you just say, yeah, give me a patient, give me a reporter, whatever it is, you do it. So this was on national news, and they talked about stress, and we looked at stressful dates by occupation. So if you're an accountant, what's a stressful date for a person that does individual tax returns? Well, it's April 15th. And what if you compared that to accountants that didn't do individual tax returns but did corporate tax returns? They don't have April 15th. They're every quarter, so it's no big deal. Well, they looked at the owners of the actually accountant offices and said, let's look at the groups that do the individual taxes. Here is in January, they had a cholesterol of 210, and then it goes up by April 15th, and then it starts to come down afterwards. While the accountants doing corporate returns, you can see there's no difference. And you can say, yeah, but these guys, they get busy, they change their lifestyle, they eat differently, et cetera, et cetera. Well, they tracked all that. It wasn't a weight thing, it wasn't a lifestyle, it wasn't diet, it wasn't exercise. They tracked all that. So it's just the stress. And so the highest is during severe stress. After the stress, it goes down. The thing that also was worrisome to me was your blood clots more when you're under stress. And the thing that really bothers me the most, and that's what the Wall Street Journal and NBC News picked up on, was that people, you talk to them about stress, and they say, yeah, I'm under stress, the patients, but doc, everybody has it. Or doc, I live on stress, I thrive on it. Or the CEOs I see, the classic line, doctor, I don't get stress, I give it. And I say, listen, if you're given stress, you're getting just as much back, believe me. And what has been shown to be helpful for these folks is to lower their stress by different techniques, and it lowers their risk of heart attack. So one last thing I want to cover is heart attacks and aspirin. And the reason I want to cover it very briefly is that with a risk calculator, you can also use that to suggest aspirin. So aspirin therapy, it helps reduce MI in men, stroke in women, but not heart attack in women. And the issue with the aspirin is that as you go through life, your risk of heart attack goes up. But as you go through life, your risk of bleeding goes up on aspirin. Which goes up faster? Your risk of heart attack or your risk of bleeding on aspirin? Bleeding on aspirin, it goes up a lot faster. And so the point is, you need to know three things: the risk of an event. You've already calculated the risk of the event. We talked about that. Know the benefits of aspirin and know the risk from aspirin. So it depends on the age of the patient, in their 40s, 60s, or 70s. Their GI bleed, you can see the GI bleed goes up as they go through life. Their stroke or hemorrhagic stroke stays about the same. And you can see that if it goes up during life, you have to have a greater risk of a heart attack later, to be able to benefit from the aspirin. And so if you look at their 10-year risk of 3%, 9%, 12%, these are the three numbers I remember. If you're in your 40s, up to age 60, so 40 to 60, if you have a 10% risk of a heart attack, stroke, or dying, then aspirin is helpful to you because it's going to cause 9 events, but it'll prevent about 10. If you're in your 60s, you need to have a risk of about 25%. You can see, look at all the numbers here. It's I actually have to keep this on the wall in my office because it's so variable for every patient. But patients are always asking, should I take aspirin? So at least this is some science behind when to give the patient aspirin. And so those are the three numbers. In your 40s to 50s, you should have a 10% risk. In your 60s, you should have a 25 or a 9%. I'm sorry, I said it wrong. 3% risk in your 40s to 50s, 9% risk in your 60s, and 12% risk in your 70s on your calculator. If it's that or above for that age group, then suggest aspirin. Does that make sense? It's a difficult concept because one line's going up faster than the other, and I always get confused with that. I think this is just a repeat. It just shows you that the harm goes up quicker than the benefits. This just walks you through it. In the slides, are they going to have slides available, or?
It'll be on the website.
Website, good. So this just kind of walks you through it. If you have a nurse that does a lot of your work or a front office person, you can actually show it to patients and they can figure it out for themselves. I'm perseverating here. I don't want to make anybody seize. I apologize. And then can we further predict risk? Everybody wants their genes. Everybody wants to know their genes. And this came out of an article in Lancet about a year ago. And it said if you had a low genetic risk, and there's about 50 different genetic factors, of which I talked about a couple of them, which was the blood type. If they had low risk in the green, intermediate risk in the yellow, and high risk in the red, you can see that giving them a statin, actually they got better benefit, more reduction in events if they were high genetic risk on top of their other risk. And in fact, if they were low genetic risk, the statin actually caused more problems than it helped. So this is not ready for prime time. At Mayo, we do not even have a test we can do with the 50 different genetic markers. It's much more effective just to look at the patients, smell them if they have smoke, see if they can see their junk or not, and that's the best. So the key points: 50% of women are low risk throughout their lifetime, up to age 79. 50% of men are high risk at some point in their life. Over half of the events that are going to occur this year are not in high-risk patients. The pool cohort equation is the best risk estimator, and the clincalc.com is the best way to get to it. Use the additional risk factors in patients that are kind of intermediate risk, and then coronary calcification is clearly the best risk, and you can go to the MESA NHLBI webpage. So one of the things we're going to have in the future too is something that's going to increase my risk for a heart attack, which is called ICD-10. I just want to finish with the ICD-10, the top, I think, the best ICD-10 codes. Number 10, bizarre personal appearance. I mean, come on. Bitten by a pig, initial encounter. Struck by a duck. Or this one we can all relate to, problems in a relationship with in-laws. You wonder why these two guys came here from India, to get away from their mother-in-law. Now, my wife is here, and I love her, and her mother is very nice, so I apologize. You walked into a lamppost, that must be like in New Orleans on Bourbon Street or something. Or you have a burn due to water skis on fire with a subsequent encounter. But swimming pool of the prison is the place of the occurrence of I didn't know prisons had swimming pools. Spacecraft collision injuring the occupant. I mean, how many, has that ever happened? I think a meteorite has hit one person in the history of the world. I never know of any spacecraft hitting any person. Struck by a macaw initial encounter. And these are all good, but I'm telling you, the number one is the best. And we all know this guy. I'm just using him to make a point. I don't always get sucked into a jet engine, but when I do, I use ICD-10 code WC. Thank you for your attention. I appreciate it. I'm sorry if I...
Oh, no, you're perfect. Thank you, Dr. Kopecky. I have one question. We have a lot of patients who come in and say, I don't want a statin, or I've been on a statin before and I've had muscle pains or the statin myopathy.
Yeah.
What's your perspective on it, and is it actually real, and what can you do to treat it? Or...
Boy, what a question. Is it real? You know, the problem with all the early statin studies, as many people are aware, is that they asked patients, are you statin intolerant? But even before statins were out there and they knew it, if you look at the heart protection study, which was the first study that really showed statins reduced total mortality, they had a 10-week run-in phase where they gave people statins, 40 milligrams of simvastatin for 10 weeks. If you didn't tolerate it, you were a screen failure. You weren't intolerant because you hadn't been randomized. So the FDA just said, okay, screen failure. Well, the drug companies knew that people were going to get muscle aches with statins. So that's why all the randomized trials show maybe 2% of patients have intolerance, because they've either given it to them as a run-in phase or they've asked them, are you intolerant? If they say yes, you can't go in the study. So the actual real life, for those of us that treat, we have a statin intolerance clinic at Mayo. I've seen about 1,000 patients in it. It's about a 20% rate of having some sort of statin intolerance. And the main thing is muscle. The issue there is that they get muscle aches. We have a questionnaire we give them that actually asks 4 or 5 questions. It should be symmetrical, should be bilateral, should be proximal, should come on within a few weeks of starting the statin and go away within a couple of weeks of stopping the statin. If they do that with 3 or 4 statins, that's the best data we have. It's not like we can order a troponin and say, oh yeah, there's a heart attack, there's a statin intolerance. So it clearly is an event. The 3 numbers I remember with statin intolerance is 75, 50, and 25. 75 is 75% of the patients that are statin intolerant can take some statin, maybe a different statin or a lower dose every other day. We've had great success with rosuvastatin a couple, 3 days a week. So 75% can take something, and something's better than nothing. 50%, that's the number of patients that will get muscle aches if you give them the same statin back, blinded. So if you give them the same pill back, this was called the imposter study. They actually did that. Took their same bottle and put it in a new package and gave it back to them, a new pill. 50%, and then 25%, that's how many people get the same muscle aches on placebo. So, if you want to say, listen, this is going to be the best drug ever, and this is going to make you feel wonderful, and you're going to live forever, they'll feel great. If you say, God, this pill is going to make you hurt so much, and you're going to hurt all over, and oh, this is going to be the worst thing ever, they're going to hurt. Now, obviously, there's a lot of room in between, because I'm statin intolerant. But I woke up one morning, I could not get out of bed. I thought I had rheumatoid arthritis, and I was on simvastatin 40. And I asked my internist, like a good doctor at Mayo, I don't treat myself, and he said, gosh, he was an oncologist. He says, it only happens in 2% of people. So I stopped it, and in about 2 or 3 days, I could walk. So I think you need to, number one, recognize to patients that it exists. Don't ignore them. Don't tell them they're full of it, because they're very sophisticated now, and they understand, and they go on the internet.
All right, we have time for a few questions. If you would, raise your hand, stand up when we call on you, and speak loudly so everyone can hear. Yes, please.
Yeah, I've seen a lot in the literature, a couple of articles anyway, where they talk about using non-fasting lipid profiles as opposed to fasting lipid profiles.
Yeah.
What do you think?
Yeah. The question is, what about non-fasting lipid profiles? And there's a couple things about that. One is, if you do non-fasting, the triglycerides can be very high. And so you have to negate that. And triglycerides are used to calculate LDL. So in that case, just use non-HDL and add 30 points to your goal. So if the goal was 70, you'll make it 100. What we're doing at Mayo, we're actually going more to apolipoprotein B, because that's the receptor site on the LDL. Every LDL has one ApoB, and that's the receptor site that causes the atherosclerosis, and that can be done non-fasting. So a lot of the non-US studies now are being done with ApoBs and not even doing LDLs and all those. Over there. Over here.
Yes.
How low do you go? And the patients that are statin intolerant, they can't take it for 40 or 20, but they can do 10 3 times a week or 4 times a week. Do you use the stat? Do you add ezetimibe? What are you seeing over a couple of years of sort of treating to what they can tolerate versus treating to what they guidelines?
Yeah, so the question is, what if they can't take a full dose statin, can't get to goal, take 2 or 3 days a week, you know, do you add ezetimibe, do you go to something different? That's a great question, and the new ACC/AHA guidelines that came out about 6 weeks ago for additional therapies to statins did say ezetimibe should be number 1. Ezetimibe did what the FDA asked them. They did a study with and without ezetimibe versus a statin in all groups. They showed benefit with a number needed to treat of 39 post-coronary disease, and the FDA still said, well, sorry, that wasn't good enough, we're not going to prove it. But it still shows benefit. So ezetimibe is a good one. I would say, you know, the goal depends on the patient. If they, I've had patients that have had LDLs in the 80s, but are getting recurrent stents and recurrent disease, and they can't tolerate statins, so then you think of a PCSK9 or something like that, or if ezetimibe doesn't help. Others, you know, I've had patients with LDLs literally 320. Saw a lady last week, 65-year-old lady, no coronary calcium on 320 LDL. And I said, does anybody in your family have high cholesterol? Yeah, we all do. Anybody have heart attacks? No, none of us do. So it's a different, you know, it's a different disease in some people. So try to match it to the patient. And if they say, you know, if they're asymptomatic, they have normal negative calcium, say take what you can. Let's accept the goal you can. The last group of patients is the ones that you can treat early in life. So it's been shown that if you can treat someone very early, like say in their 40s or 50s, get a 10% reduction in your cholesterol in your 40s, that's equal to lowering your risk throughout your lifetime by getting a 50% reduction at age 65. So just a little bit early helps you, and it's just like saving for retirement. You know, do you save a little bit every paycheck, or do you wait till you're 64 and a half and buy a lottery ticket, you know? Which, just stay, you know, do a little bit every.
Yes.
The question is, do women benefit as much from statins as men? If women do not take statins as much as men, they want to do alternative therapies much more than men, which is certainly fine. If you look at all women, they probably don't, because they're lower risk in general. But if you age and sex match, or age match and risk factor match a man and a woman, then she benefits just as much from the man as taking the statin, if everything else is equal. Does that make sense?
Yeah, I just asked because one of your colleagues, I think in Rhode Island, wrote a book claiming that women don't benefit, and that it's masked by the fact that we don't report women separately from men in clinical trials, including the one that Zetti did.
Yeah. Well, so the point was, there was a book written by someone in Rhode Island that says the women don't benefit.
The Truth About Statins is titled.
Oh yeah, The Truth About Statins. If you look at that book and look at any studies that have actually matched the risk factors and the degree of disease, the women benefits just as much from LDL lowering, which is a little different question than the one they posed in that book. Okay.
Want to make a comment on third-hand smoke?
Third-hand. So first-hand smoke, you smoke. Second-hand smoke, you're in the room with someone that smokes. Third-hand smoke, go outside. So in Minnesota, you know, we have, I'll ask your grandmother, do you ever smoke in the house with the grandkids? Oh God, doctor, it will be 40 degrees below zero and I will go outside and smoke. I will not smoke in front of the grandkids. I said, that's really good of you. Do you ever come back in? And do you put the grandkid in your lap and he says, oh, Granny, you smell like smoke. Well, yeah. Well, you know, if they smell it, guess what? They inhale it. If they inhale it, guess what? They absorb it. So they found the smoke, they found vascular effects, endothelial effects. They found the carcinogens in the kids' bloodstream. They see the carcinogens on their skin, which they can absorb in their skin. I think it was here last year we talked briefly about the third-hand smoke. Is it changed much in California? Because I think this is where it may be the leader of the field, that selling a house. You know, we remember a few years ago, you sold a house and it had mold. And so they called you and they said, oh, you got to take this house back. It gave me mold sickness. And now the thing that's starting to happen around the country is there's smoke in there. There's smoke on the walls. There's smoke on the carpet. I'm getting exposed to smoke and I'm having problems from that. And now they're coming back to you and saying, okay, that was your fault. You sold me the house. And once the lawyers get a hold of that, it's going to be interesting because there is science behind it that shows there really is, you know, if you smell it, you know, Mr. Clinton, you inhaled it. I'm sorry. You know?
All right. Thank you, Dr. Kopecky.
Okay, thank you.